apologies. Okay, so it's that of the history I've got is that of a 61-year-old female patient who is a smoker with no comorbidities and presented to Mitchell's Plain District Hospital with a 3-week history of loss of appetite, loss of weight, and diarrhea. And there is this history where she actually presented in septic shock and required inotropes. When we spoke to them, we had a blood culture that had flagged positive, and they had no source of sepsis or focus of sepsis, and the patient was started on empiric ceftriaxone and metronidazole. They had no focus of sepsis, and we weren't sure exactly what we were treating. So we had advice that we were given based on this, and we actually said, since we've got a gram-positive cocci, we've got gram-positive cocci in chains on a blood culture, please look at the patient's skin, any chest issues, any collections intra-abdominal or in the chest, any occult collections that may require imaging, and to consider repeating blood cultures. In addition, the patient was also noted to have a biocytopenia and actually presented with a lactate of 14 on admission. So based on our gram stain, we thought that it might be a streptococcus, and streptococci can largely be divided into 3 groups based on the type of hemolysis it causes on blood agar that we observe. So the hemolysis that we note is partial hemolysis. So you'll observe this green tinge on the blood agar, or it can be beta hemolytic, which has complete hemolysis. In other words, you can actually put maybe a newspaper or whatever behind the plate, and you can see those letters. Or gamma hemolysis, where there's no hemolysis at all. And those each of these types of hemolysis is usually seen with specific organisms, such as so alpha hemolysis. We usually think of Viridan strep as well as strep pneumoniae, and then your beta hemolytic colonies we'd often see with group A strep or strep pyogenes as an example, and then your gamma hemolytic colonies, which we would see with our enterococci. So this is just an image depicting that. So it's got it alpha, beta, and your gamma hemolysis. So on day one, we had no growth on our plates. And usually in terms of the, if you just recall the image that I just shown you, we'd usually have growth on our plates of either alpha, beta, or gamma strep. They usually grow quite readily on our usual media. So based on the history that we were given, the patient sounded quite ill, and in that instance, we actually considered nutritionally variant strep. As you can see, when it comes to that classification in terms of hemolysis, there's not a space for nutritionally variant strep in that classification. So what we did then was to put a Staph aureus on that on the plates to see if there would be any growth, and this is what we observe. So basically, what we are doing is we put a Staph streak, which is the white, the heavy growth that you see there, and we use it as a helper organism, which allows for diffusion of compounds such as pyridoxine into the media, and allows for that strep to actually grow around those colonies. And the helper colony supports this, and you can see that demonstration on the second day. And as such, we were then concerned about endocarditis, or once again, collections. So we were then we then spoke to the clinicians at Mitchell's Plain, and we got additional history. So the patient, this is now history from medicine. The patient had an HP of 6. She had a purpuric rash, apparently normal heart sounds, and there was a concern of liver pathology with increased ALK phos as well as iron R. Apologies, the iron R was 1.5, and she had an albumin of 12. She also had in addition, she did have an ultrasound in the EC, and they were concerned that there might be a mass in the liver. The patient then went on to that organism was then identified, and we had a Granulicatella adiacens. And based on that ultrasound, she went for a formal ultrasound, which showed multiple cystic lesions on that ultrasound, and she was subsequently transferred to GSH for imaging and concern of endocarditis at the time, as well as and received an echo. So just a note on nutritionally variant strep. So in humans, or we usually have three culprit organisms, Abiotrophia defectiva, and then in terms of your Granulicatella, we have adiacens as well as elegans, sorry. And then these are usually found in the oral and GIT systems. And risk factors for these organisms are usually associated with poor oral hygiene, as well as IV drug use, and then possible underlying GIT malignancy. The source of bacteremia is often thought to be due to infective endocarditis. There might be associated skin and soft tissue infection, bone and joint infections, and as we said, it is often associated with intravenous devices. Okay, so in the lab, this organism is quite difficult to isolate because, or it's actually quite easy for us to miss because the organism requires media that is supplemented with cysteine and B6, and we don't have this media available. And this poses additional problems in terms of susceptibility for susceptibility testing in our lab. So in terms of the identification methods that we have available, we have the biochemical Vitek2, which we have in our lab, and then MALDI-TOF as well as 16S. So of these two, we only have Vitek and our 16S PCR. Looking, when comparing the Vitek with the with MALDI-TOF, we see that MALDI, so this study is quite an old study, looking at how often Vitek is able to actually isolate or identify Granulicatella to the species level. Unfortunately, it's from 2013, and it's very small. There were only 14 isolates. When we can see that although MALDI-TOF was able to correctly identify all the isolates, and Vitek2 only managing to identify 9 of them. Just of note, they use 16S as the gold standard in this study. Then just looking at the susceptibility testing and the problems associated with that, we just need to note that when it comes to the MICs, they are lower for Granulicatella compared to other viridans streps. So this is according to the American Heart Association. So they've actually changed or reduced the breakpoints. CLSI would say that intermediate would be between 0.25 to 2 and resistant more than 4. So we can see that that's already much lower in the AHA guideline, then that's the recommendation. So it's almost adopting a similar breakpoints as for enterococcus, or not breakpoints, treatment as well. So you can see the recommendation there is usually penicillin and gentamicin if the MICs are known, and then vancomycin with or without gentamicin. And actually, ceftriaxone is not considered in this instance, despite it being possibly, it might actually work. But just of note, as you can see, they looked at susceptibility patterns for these organisms, and you can see that between 57 to 70% of the Granulicatellas are actually resistant to penicillin, and 65% were actually susceptible. That's susceptible to ceftriaxone, compared to your abiotrophia, where up to 85% of them are resistant to penicillin. Okay, so just when it comes to susceptibility testing, so there's no commercial method available. And although e-tests are readily available, it requires special media. And e-tests are more for research purposes, with broth microdilution being the gold standard. And just with this, when comparing e-tests to broth, we already know that vancomycin has issues with diffusion in the agar, being at a large molecule, and there were actually there was poor correlation with vancomycin e-tests and broth, and also very high major error rates with ceftriaxone. So an example, just so that you know what I mean, is that it would call ceftriaxone susceptible on e-test, when in actual fact it would be resistant when compared to broth. So that's basically just saying what I've just said. And then penicillin seemed to have a good categorical agreement, as well as essential agreement at about 86% there. So just in terms of Grooteskeer, in terms of the isolates that we've had, so between 2015 and 2021, we've actually had 21 of these nutritionally variant strips that we've isolated. 5 are duplicates from repeat blood cultures, and of them, there were 3 associated with endocarditis. 1, which is this case, which is a right-sided endocarditis, and 2 others which were due to a left-sided endocarditis, one of which was a pediatric patient who had underlying valvular heart disease. Okay, so so this patient, in addition to having a vegetation on the tricuspid valve, she also had pus that was sent to us, and we isolated anaerobes. A staph streak was performed, and however, it was quite difficult to say whether or not that strep was present. And this patient then remained on vancomycin as well as metronidazole. So just from our side, we generally recommend vancomycin due to the limitations of our laboratory in terms of susceptibility testing. And then these patients often complicate, so ID consultation is usually warranted due to relapses or bacteriological failure.
We've lost you, Ghowa, your voice. Sorry, has anybody else lost Ghowa, or is it just me?
No, you're not alone.
Yeah.
Okay, thanks. Ghowa, if you can hear me, perhaps if you stop sharing your screen, and because we've lost you. Thanks. I don't know whether if you perhaps might have to come out and then go back in, come back in. That might be the best thing to do. Obviously, we'll thank Ghowa in a minute when she rejoins. But who was the microbiology consultant working with Ghowa on this, and could you make some comments? Whoever is will have to unmute.
Hi, Amanda speaking.
Hi, Amanda. Thanks very much.
It's Amanda speaking. So I was involved mainly after the second blood culture had flagged positive on this case. And I think the thing really and truly was the forward thinking of that it hadn't grown and the staph streak as Ghowa had already mentioned, and to really try hard in communications with the clinicians to rule out endocarditis, because initially they had said there's no murmurs and no concerns of it. So I think upon reculture, it was really to reinforce that information and to ask them to look harder for the source of the organism itself.
Okay, thanks very much. And Elizabeth or any other of the micro consultants, you want to make a comment? Elizabeth, I saw you unmuted.
Yes. These just to highlight that these are really tricky organisms, and that in the guidelines in the American Heart Association, they don't always go or recommend always going straight for Vanco. They say that you might try pen and Genta or ceftriaxone and Genta, but I think Vanco was gone for because these are uniformly susceptible in very small studies to vancomycin. The duration of treatment is not that well elucidated, but I'm guessing it's probably about 6 weeks or so, which is quite a long time for vancomycin.
Thanks very much. I mean, can I just, Ghowa isn't with us yet, but one of her comments struck home to me, which was the vancomycin, she was recommending vancomycin predominantly because of limitations of the laboratory, quote unquote. I mean, how much of that really is an issue, and how much, how should that really be allowed anymore? I mean, stewardship being what it is, if that's really the case, then how do we alter that? I don't know if Elizabeth or Amanda, as heads of the lab, Elizabeth, you'd like to tackle that one.
Yeah, I'm not too sure how we alter it, because it really is quite it really is quite complicated susceptibility testing. And I think you really have to just go with what the literature says, and which I don't think is necessarily vancomycin for such a long time. I mean, I'm not too sure whether she had a very big vegetation or that sort of stuff, but yeah, I mean, I think it's a bit difficult, and I think people get a bit nervous, and that's why they rather opt for Vanco, because it's known to be susceptible, whereas in smaller studies, like Ghowa mentioned, the penicillin and the ceftriaxone have been shown to be resistant sometimes in a percentage of patients.
But if your advice is being given because of a limitation of your laboratory, how do you unlimit your and set it free, as it were?
I don't know. because the disc correlations are not, disc and e-test, they don't correlate well with this broth microdilution. And you might ask, well, why don't we implement broth microdilution, except even the broth that's used in the broth microdilution is difficult broth. It has to be the cysteine and pyridoxal supplemented broth. And some people even say that there's that it's difficult to interpret and can be prone to errors. So I actually don't know how we get rid of that limitation in the laboratory with regards to these organisms.
So thanks. I know Sean's waiting, but I see Amanda put her hand up while you were speaking. Amanda, is this about this question? If it is, please go ahead, and then we'll come to Sean.
Yes, it is. It is, Prof. It was just also to add on to the point that Elizabeth has made, that it's not in essence a GSH micro lab limitation in that it is a national one to source the availability of that media for doing susceptibility testing for broth and also for disc diffusion based testing. So it's not just only for Tiscare, it's a national thing of obtaining the media in itself.
So we need to direct our...
And also, other than that, sorry?
No, go ahead.
And also, other than that, it's also the how often you would use such a media in terms of susceptibilities, in terms of how frequently do you isolate it to introduce such an assay.
Sure. Okay. Point taken. Sean, you had your hand up.
Yeah, thanks. So I have a couple of questions, and a new one just came up now as Amanda was speaking. So maybe I'll ask that one first. I mean, in a reference lab where the phenotypic susceptibility testing can be done, right, with the correct broth, etc., have studies not done, or are they not possible to determine genotypic correlates of resistance to, say, penicillin? And if there's a limited number of mutations that are associated with resistance, then that could potentially be used as a diagnostic test, right, for resistance testing. And I guess that's a broader question for microbiology in general. In my kind of knowledge of this comes from TB, where there's active research in this area. So that's my first question. Perhaps someone can respond to that first.
So Elizabeth or Amanda, would you like to take that on?
Yeah.
Amanda? Oh, sorry, Elizabeth, whoever.
Yeah. Gosh, Sean, I'm not too sure. I think these organisms are so rare that there haven't been many studies on them. Especially, I must say, I haven't come across anything in terms, I mean, I know it's PVPs are usually the resistance mechanism, but I haven't come across much more than that. So I'm afraid I can't answer your question fully.
Yeah, no, I mean,
Hi, Sean.
yeah, go for it.
Sean, how are you? Sorry. So Elizabeth, what Elizabeth has said is correct. There isn't much information in terms of that as well as yet. I mean, the only thing that I've come across is the MEC-F mechanism gene that they speak of, and that's for clindamycin and erythromycin. So that's not really helpful for penicillin, and the PBB is usually what we would look at.
Okay, and Sean, we've got it. We're running out of time, but if you got your second question, we can take that.
Yeah, so I mean, this is going to expose my ignorance. So don't you guys sometimes put positive blood cultures directly onto the Vitek? And if you do, then why doesn't that work here? And you know, I know it's like a really kind of interesting process to do the stash streaking, and microbiologists probably enjoy that. But can you not bypass that and just get a quicker answer with automated testing?
Sean, so it's only been validated for gram-negative organisms, for gram-negative bacilli. I don't know, Elizabeth?
Yeah, for the Vitek, it's really only for gram-negative bacilli. And it's funny, even if you want to do directs on moldy tough, they work better with gram-negatives than they do with gram-positives. which I mean, they do work with gram-positives, but it's more of a process. And so I'm not too sure if gram-positives are slightly more tricky and not that amenable to direct testing. I couldn't say why though, than are the gram-negatives. I mean, unless it's got to do with growth rate or something, and gram-negatives grow much faster. But for the moldy, that shouldn't be a problem. So I